All right. Good afternoon, everyone. My name is Donna Gunkel. I am the Director of Clinical Integration here at United Medical. Today is Friday, December 6th, and this is our monthly wellness webinar for our diabetes program. I will be the host today as Kamal is out of the country. And thank you, Caroline, for sharing the screen. So if you want to go ahead to the next slide. So I want to introduce our program team. So like I said, Kamal is our chairman and CEO of United Medical ACO. We also have Dr. Hundle, who is one of the endocrinologists in our network for First State Endocrinology, and he is the program director. And we have Caroline Weber, who's here with us today. She is our lead dietitian for the diabetes program. And then we also have two social workers that support the program and the ACO in general, Roxana Portlock and Carla Williams. So our diabetes wellness webinar program, so like I said, it's once a month, and we host this once a month, and we have a variety of providers that we have join in with us so that we can go over how diabetes may interact, or how you may have other illnesses or diseases that affect your diabetes. So we have endocrinology, cardiology, nephrology, podiatry, our social workers, physical therapy, and many more. So today we have the pleasure of having one of our cardiologists, Dr. Vinay Hosmane from Hosmane Cardiology, and Caroline Weber. So they are going to talk to us about heart disease and diabetes today. So I will turn it over to you, Dr. Hosmane, so that you can get us started.
All right, good afternoon. We're tasked with talking about a little bit about heart disease and diabetes and how they interplay. So we'll just go ahead and start. So what is heart disease? It's kind of a catch-all term that gets a little bit confusing, and it covers a couple different entities. And the most common entity that we think about when we say heart disease is coronary artery disease. So coronary artery disease, or CAD, is basically blockages with atherosclerotic plaque in the coronary arteries. And the coronary arteries are arteries that actually supply blood flow to the heart. So if somebody says I had a heart attack, it's usually that one of these arteries got blocked. Heart disease also includes abnormal heart rhythms and actually congestive heart failure. The other thing, I just put a little asterisk in there. Erectile dysfunction is not traditionally considered heart disease, but it often precedes the main form of heart disease, CAD, or coronary disease, by 5 years. And I put that in there because a lot of people with diabetes unfortunately have erectile dysfunction, or if men have erectile dysfunction, it's kind of like the canary in the mine. And it's something that's not frequently taught, but it's something that we should pay attention to when we're taking our histories or we're talking to our doctor or healthcare provider. It's a little bit embarrassing to talk about, but erectile dysfunction does precede heart disease, often by 5 years per the literature. So the main risk factors for heart disease are hypertension, high blood pressure, high cholesterol, or the more medical term is hyperlipidemia, and tobacco abuse. And marijuana smoking, which is now pretty much legal, has not been written up much in the literature in the past about being associated with heart disease, but there are some recent articles that are coming out, and cardiologists are recognizing that smoking marijuana is actually now associated with heart disease. Marijuana obviously has some medicinal benefits used in different ways, but we feel that smoking, which seems to be a little bit more prevalent, or at least people are admitting it to more, can still be a problem. And there's also diabetes. There's also a risk for heart disease, and diabetes also, along with a bad diet, inactivity, and excessive alcohol or binge drinking, actually contribute to heart disease. Recently, there's been some things in the literature that are saying that, 2 drinks for a man, 1 drink for a woman daily may not be the way to go. For example, a male over 65, now it's recommended they should actually cut it down to 1 drink a day. And you won't find cardiologists anymore advocating that if you don't drink, that you start drinking wine, because there's definitely some detriments to drinking, especially binge drinking. Next slide, please. So I just wanted to give my layperson's definition of diabetes, or what really happens with diabetes. Caroline can give us a better definition, but I always say that it's the body's inability to regulate insulin. And insulin is really what regulates our blood sugar, right? We all know that people who have type 1 diabetes, for example, don't produce insulin, so they have to inject themselves with insulin to take the blood sugar that's running around the pipes and the veins and put them to the organs and put them into the muscles where they need to go. So with diabetes, the body's unable to regulate insulin. That's typically type 2 diabetes, which I think what we're focusing on more today. And the pancreas is the one that produces insulin, but it produces less insulin, and actually the cells don't respond to the insulin. So in early disease, this actually may be reversible if the metabolic stress of excess fat is decreased in the pancreas. There's a lot of talk out there about fat in the pancreas may be what's causing the problem. So you'll see a lot of things about plant-based diets and pushing more towards fruits and vegetables and grains. And one of the theories there is that by decreasing fat and having these other healthier nutrients, you're actually decongesting the pancreas. The test to figure out if you have diabetes is generally the hemoglobin A1C, but also fasting blood sugar is used. There are also a couple more specific tests that I won't get into, but just think about hemoglobin A1C and fasting blood sugar. And it's a test that measures the average sugar in the blood that's attached to hemoglobin over the prior 3 months. Some people will say 2 to 3 months. And hemoglobin is the part of the red blood cell that carries oxygen. And unfortunately or fortunately, glucose sticks to the hemoglobin, and that's how we're able to tell somebody's diabetic control. Next slide. This is something I took from one of the Cleveland Clinic articles, thinking that this would be a good reference point for providers and our United Medical clients. And you can pretty much see that on the left-hand column, that's hemoglobin A1C. This is a test that we're talking about. And pretty much if you're 6.4 or greater, you're considered to be diabetic. If you're pre-diabetic, if you're 5.7 to 6.4%. And if you're less than 5.7, you're in range. And if you look over to the right, just to get a kind of idea of what blood sugars tend to be. So if you're diabetic and your A1C is 6.4% or higher, generally your fasting blood sugar is greater than 137 milligrams per deciliter. But there's a lot of variations here, but I thought this was a good chart to look at, because sometimes we'll get somebody comes in and says, what was my A1C? You think it came down, and the A1C wasn't ordered, and then you have a fasting blood sugar and you're trying to backtrack and give them an estimate. But of course, the fasting blood sugar can be pretty labile depending on conditions. Next, please. I also want to just touch upon metabolic syndrome. Metabolic syndrome to me is kind of a warning, and it's something that's not talked about as much. We focus more on diabetes, but metabolic syndrome, does convey a risk to heart disease. And it's a similar entity that's hiding under the radar that's often not acted upon. And many of the same diabetic principles of treatment apply. And the reason I mention this is my pet peeve is people having prediabetes for a long time, and we just watch it and we just watch it. But when you start thinking about prediabetes and thinking about it in the context of metabolic syndrome, and if you read about metabolic syndrome still conveys mortality and morbidity. It conveys a health risk. And the definitions of metabolic syndrome is you have to have a couple of the following. I think it was two of the following: excessive weight, a waist greater than 40 inches in males, greater than 35-inch waist in females, or elevated triglycerides and low HDL, or a fasting blood sugar 100 plus, or elevated blood pressure with a top number, which is systolic 130 or greater, or a bottom number 85 or greater, which is the diastolic. And generally, these clients don't have a true diagnosis of hypertension yet or diabetes, but they have precursors that still convey risk for diabetes, heart disease, and stroke. So this needs to be addressed. There should be a low threshold to treat with medications and really treat aggressively with lifestyle modifications, not just watch and wait. If you look up metabolic syndrome, there's a lot of data there that again talks about that if you have two out of these four components, you could actually be at risk of heart disease and stroke. And I feel we have a lot of patients that we see who have a little bit of elevated blood pressure. They have a little bit of elevated blood sugar. Their waist is a little bit elevated, and they want to wait. I mean, wait for what? The disease process is happening. A little bit of high blood pressure, a little bit of prediabetes. We have the notion that it's okay. It's not okay. So just think about if you have a little bit of a higher waist size or elevated triglycerides or fasting blood sugar, a little bit of elevated blood pressure, and your provider tells you you can wait. I'm not saying that you necessarily should start medicines, but you should not wait for lifestyle modification because the disease process still goes. And, my general motto in my practice is shoot first, ask questions later. You have to start treating these things and then worry about why, or, oh, I drank too much Gatorade yesterday, or it was the holidays. And I see people over the holidays who become metabolic syndrome, and then after the holidays, they don't. Well, and they don't want to change their lifestyle or take medications, but you're still causing disease during the holiday time. And it'll be interesting to see what Donna and Caroline have to say about this. Next slide. How does diabetes cause heart disease? It damages blood vessels and nerves in the heart via oxidative stress, inflammation, and endothelial dysfunction. And the endothelium is the protective cells lining the blood vessels or the pipes. So the high blood sugar is directly caustic. It's kind of how you have to think about it. It's directly toxic. Thus, because of the above damage, there's accelerated buildup of plaque, which is typically cholesterol, and we call it atherosclerosis. And there's also the sugar also causes bad heart rhythms because you damage the nervous system and the wiring in the heart. Diabetes in of itself, having a history of diabetes has been declared as a coronary artery disease equivalent. We have to look at diabetics as if they already have had a myocardial infarction. Even if a diabetic has not had a heart attack, you still want to aggressively treat them as if they've had a heart attack. If somebody sprained their ankle playing soccer, the chances are they're going to sprain that same ankle again. So if somebody's had a heart attack, the chances go up that they're going to have a heart attack. So a diabetic should be looked as if they've already had their first heart attack. So diabetics without a history of a heart attack have the same risk for heart attack as non-diabetics who have already had a first heart attack. So the CDC says that diabetics are 2 times as likely to have a heart attack or stroke than those without diabetics. So again, diabetics are 2 times as likely to have a heart attack or stroke than those without diabetes. So we have to be aggressive. So the damage doesn't wait for us to get past the holidays. The damage doesn't wait for us for another 6 months. Well, doc, I know I'm diabetic and my A1C 7. I want to wait another 6 months. Again, wait for what? You're waiting for a heart attack. Next slide, please. Symptoms of heart disease, just in general, exertional symptoms, symptoms with activity are always concerning. So are any symptom with exertion that you have that keeps coming with exertion, you want to seek medical attention. And some other warning symptoms are chest pain, neck pain, jaw pain, left arm pain, typically is a squeezing or a pressure, having shortness of breath, having fatigue, having palpitations, having dizziness. You need to talk to your doctor. If these symptoms are not letting up, you need to call 911 and go in. And so many times these are some of the reasons why we have referrals. And also United Medical Clinic is triaging diabetics and getting them in front of a nephrologist or cardiologist or podiatrist. Not everybody necessarily has to go, but you have to listen to your provider, and they generally do a real good job at triaging who needs to go to a specialist. Next. So what do we do to assess and prevent heart disease? There's no set recommendations for everyone at a certain age just to show up at a cardiologist's office and get a stress test without symptoms. So we're kind of focusing on heart disease here. The guidelines basically tell you if somebody's at risk, they should get cardiovascular testing. And generally that at risk is done by a cardiovascular risk score calculator that the clinic will do. In patients that don't have symptoms. So you want to know your numbers. You have to know your blood pressure numbers. You have to know your A1C, your glucose numbers, your cholesterol numbers, your blood pressure numbers, your weight. All these things go into risk score calculators. So when it comes to heart disease, everybody thinks that they should get a stress test. Generally, I think everybody should have their risk factors managed and undergo lifestyle modification because stress tests only detect 60 or 70% blockages in the heart. So people think that if they've had a stress test, they're good. Well, you may not be good because you could have a 40% blockage that stress test doesn't pick up. And stress tests don't always detect abnormal heart rhythms. So you need to have a discussion with your primary provider and know all your numbers and go to your provider regularly so they can assess for symptoms. They can look at an EKG, they can look at your blood pressure, they can talk to you about any aches or pains or any heart palpitations or dizziness. So it's important to go to your provider because something that may seem trivial to you might be of more concern to your provider. We already talked about what numbers you know, what numbers you need to know, your blood sugar, your cholesterol, your blood pressure, because that allows one's 10-year risk of heart disease to be predicted. So a lot of times putting a patient in a risk score calculator lets you know whether you need to see a cardiologist or not. Something that's very important besides knowing your numbers is asking your providers to review your prior scans for plaque. Ultrasounds, x-rays, CT scans, mammograms, MRIs, all provide um, your provider the ability to say what your risk is. If somebody's risk of having a heart attack in 10 years might be 5%, 2%, maybe low, but if they actually have calcification or plaques in their arteries already, then that risk might go up to 20%. And maybe they do need to see a cardiologist. Maybe you do need to be more aggressive. And people who are listening may have heard of coronary artery calcium scores, which are tests without dye that are CAT scan pictures of the chest, CAT scan pictures of the chest that we do to see if somebody has coronary disease. And that actually helps us decide how aggressive to be with lifestyle, how aggressive to be with medication. But, asking your provider, and the providers out there are probably all going to hate me in the United Medical Clinic, but, as the providers, hopefully they're listening too, please look at a patient's prior scans because you will see vascular calcifications that are noted in the breast. That's actually atherosclerosis. You'll see coronary calcifications. That's atherosclerosis. You'll see abdominal aortic calcifications. That's actually plaque. That means your risk score is much higher and you have a higher risk of having an MI or stroke. And maybe that'll convince people to get treated. Next slide. Um, Risk factors for heart disease. We kind of covered these. We'll go through these quickly. Again, treat your hypertension, treat your diabetes, stop smoking, treat your diabetes, fix your diet, fix your inactivity. These are all going to help you avoid heart disease. And the literature definitely supports earlier treatment of elevated blood sugar and earlier treatment of the cholesterol is actually going to decrease your risk. If you're 40 years old and you start treatment versus your 60 years old and you start treatment, when the 40-year-old reaches 80 and the 60-year-old reaches 80, the 40-year-old is going to have less bad stuff happen to them because they were treated earlier, as opposed to a 60-year-old waiting 15 or 20 years not to get treated or not taking intervention. The one thing Carolyn's going to mention, exercise. Please note that walking counts. I mean, a lot of people come in and feel bad and embarrassed that all they do is walk, but walking really does count to prevent heart disease and help treat diabetes. Next. Again, treat your risk factors for heart disease. Do not shy away from meds if recommended. Disease states will not wait for your half-hearted attempts and lifestyle changes. Be responsible for tracking the numbers yourself. The risk factors that we all have didn't develop overnight and they're not going to go away overnight. So you can't be frustrated, but you have to be aggressive, right? What I don't understand is in this country, we were so aggressive with sports. We're so aggressive with our careers. We're so aggressive with getting the weeds out of our yard, but we're not aggressive with our health, right? I mean, it's fourth down and 50 yards and we're all like our blood pressure's up, our heart rate's up, our football team, you don't want the guy to punt because the punter sucks, and you want the quarterback to throw, and we're all jumping up and down and we're all bent out of shape. Or it's 0-0 double overtime and we're going to penalty kicks in soccer and us soccer fans are just jumping up and down. But nobody jumps up and down when we have prediabetes or diabetes. I mean, I just really wish that myself or our providers or clients would get just as bent out of shape about, pre-hypertension, pre-diabetes as we do about sports. Uh, and you have to start the process, and you have to trust the team's process. You have to trust your healthcare provider, right? We send our kids to go play competitive soccer, and we let the competitive professional coach say whatever the hell he wants, do whatever the hell he wants. But when it comes to our healthcare providers, people don't want to listen to us, right? So if you're trusting, the team manager, the team coach, the sporting director, please trust your healthcare provider team, and think of us as members of a sports team. And you have to trust us to tweak, retest, refocus, relearn, and trust us to be methodical. There's a rhyme to the reason. I hear it all the time. Oh, my doctor started me on this medicine, then he changed it, she changed it. They don't know what they're doing. Well, think of us as that general manager of a sports team or the coach. You have to tweak, you have to keep working at this. This is not always an exact science. Each patient is different. Next. And again, alcohol is also something that needs to be treated for heart disease. Sleep apnea is not listed as a risk factor for heart disease in the traditional sense, but sleep apnea does raise blood sugars. It raises cortisol. You have a lot of primary doctors and endocrinologists and lung doctors will tell me you start treating the sleep apnea, that fasting blood sugar will come down. We see it all the time. We treat a lot of sleep apnea, and patients report that the blood pressures and blood sugars come down. Next, and I think this is one of my last slides. I took a lot of time, but this is my soapbox. This is probably even what I'm more hyper about. Diabetics need to be on statins. Diabetics need to be on statins. Statins drop cholesterol so we don't make plaque. Diabetics have plaque for the most part. It's a coronary artery disease equivalent. Statins will stabilize plaque so they don't break and rupture, go to another artery and cause a heart attack. Statins will shrink plaque, and statins will heal the endothelium or the lining of your blood vessel so you don't make plaque. We have it in this country that statins are bad. If either they're not any worse than Tylenol or Advil or whatever else we take over the counter. There is an association between statins and blood sugar elevation, but statins prevent myocardial infarction or heart attacks in diabetics. So our endocrinologists, who know more about blood sugar than the rest of us, and our healthcare team that's been listed here, is not telling people to stop statins because it may increase blood sugar. The risk outweighs the benefits. And most of the muscle aches perceived to be from statin use are not from the statin, but they're from normal aging and day-to-day use and activity. There is the rare person that has statin muscle aches, but everybody has a cousin Frank or Susie who almost died from their statin. I haven't seen it yet. Next.
That is it.
Yep, thank you.
Um,
Sorry to take too much time.
That's okay. Thank you, Dr. Hosmane.
Yep.
One thing I did want to mention, I kind of wanted to go back to what you were talking about when you said, what are we waiting for? Why wait? I know one of the things Dr. Hundle talks about too, right, from the endocrinology perspective is sometimes our bodies get used to that elevated A1C, right? That A1C of 12 or 15, but it didn't happen overnight. So your body's getting used to it. Doesn't mean it's good for your body, right? But everybody's like, oh, but I feel okay. So
Yes.
I kind of take that to what you said about waiting. We don't have to wait till we feel bad. We don't have to wait till we have the chest pain or any of those other symptoms. So
Right.
I guess that's the real message here is to
Correct. I mean, because as diabetes, high blood sugar, high blood pressure, high cholesterol, as you're alluding to, and don't always cause symptoms. So we're not running to the doctor to get treated for that. If I fall down and I hurt my shoulder and I can't move my arm to drive, I'm running to that orthopedic or the sports medicine doctor. So I think your point's well taken, and also people need to know, and you were alluding to the fact that these are silent, and you may not feel bad.
right.
Doesn't mean you're not getting hurt inside.
Correct. Thank you. Sorry, go ahead, Caroline.
Good. Prevention matters, which is where we're going the dietary route now. We're going to talk about one of the major risk factors that Dr. Hasmani mentioned, high blood pressure. There are several different types of diets out there that we could, use and prescribe for treating heart disease, prevention, things like that, like Mediterranean. Basically, we're going to talk about the DASH diet today, which is the dietary approaches to stop hypertension. So it's very specified and specific on hypertension, but this diet plan could be applied to anybody. It's just got really basic nutrition standards that we want to make sure they're basic nutrition dietary guidelines that are important just to support health and work towards that prevention piece as well. So it was originally designed as an eating plan to lower blood pressure, but it helps to reduce cardiovascular risk factors. It can also reduce the risk of a stroke and kidney stones, but it is also very good for managing blood sugar, as we'll talk about some of the key foundation principles of this diet plan. It focuses on whole foods, rich in nutrients that have shown to lower our blood pressure, like fiber. Fiber is the one thing I will tell all patients, increase your fiber. I think like 70% of Americans do not meet the fiber guidelines, which is about 25 to 30 grams a day. Most Americans, I believe, get 10 to 15. So fiber is protective. It's protective for the heart, digestive system. It's great for diabetes management, for managing our blood sugar. So lots of fiber-rich foods. Nutrients like potassium, calcium, magnesium, and protein all play a part. We'll also talk a little bit about saturated fat and trans fat and its impact on cholesterol, also looking to lower those sugar and sodium levels to support overall heart health and decrease our risk for hypertension. Some basics just of the DASH eating plan. Reduce sodium. So average DASH sodium recommendation is about 2,300 milligrams per day. In America, we eat a lot of sodium, mostly coming from packaged goods, but also if you cook with a lot of salt, we can see that too. We see higher benefits if you decrease even more. So higher benefits for your blood pressure if you go as low as like 15 to 1,800 milligrams per day. But this is also something to talk about with your doctor. Specific needs that you might have might differ from someone else. So you want to make sure that if you have a restriction on sodium, that you're confirming that with your physician. And decrease saturated fat. So we know that saturated fats can come from animal products, high-fat dairy, refined sugar snacks. You can find it on the back of the nutrition label for those packaged snacks. So looking for ways to decrease the saturated fat, which tend to elevate the cholesterol. So focusing maybe on plant-based sources of proteins is a great way to help, reduce that total amount of saturated fat in your diet. But I like to point out that like the Beyond Burgers and things like that, those substitutes for meat, they tend to have a lot of saturated fat to help kind of make it taste like meat. So for the palpability and the taste preference for people. So read your labels if you're getting a packaged meat substitute, but I'm referring to things like beans and lentils and those high fiber plant sources that are great and protective for blood sugar management and for our heart. I also like this little visual, this 2,300 milligrams of sodium. That's 1 teaspoon. So that blows my mind every time because if I'm baking, I measure out 1 teaspoon of salt and it doesn't seem like a whole lot, but that is the recommended amount for daily intake. So that is something to keep in mind. So if you're adding salt to your food, you keep a salt shaker at the dinner table. Just keep that as a visual if you're working towards decreasing your total sodium content. Increase fruit and veggie intake. I will preach this until the cows come home. Increase fruit and vegetables. I will recommend for every person, every diet, because they contain essential nutrients, vitamins, minerals, fiber, natural sources of potassium, which assist in our blood sugar or blood pressure management. A lot of us don't eat enough, but a lot of us get caught up in, I have to eat fresh. Fresh is most important. Fresh, frozen, canned. They're all the same nutrient value-wise. Only difference is canned tends to be higher in sodium, so keep an eye on that. Look for lower sodium options. You could also rinse it in a colander. Like I rinse my beans in a colander and that reduces the sodium by about 30%. So the more vegetables, the better, right? Lots of fiber. Fruit-wise, we do want to pay attention for our blood sugar management. So if we're worried about our high numbers, small frequent intake through the day, spread it out. We know in counseling, we talk about our higher sugar fruits. We don't need to eliminate them. There's no need to create fear around fruit, but we want to make sure that we watch the portion size of those higher sugar fruits, eat them in smaller quantities spread throughout the day. I would still recommend the same amount of fruits for someone with diabetes, for someone without diabetes. So 2 to 3 servings per day. Then getting a little nutty. So this one I love to talk about because I love nuts, butters. This is a great source of unsaturated fat. So nuts are really protective because they have omega-3 fatty acids, which are great for heart health, great for lowering our bad, lousy cholesterol, rich in antioxidants, so it can reduce damage to blood vessels. So we want to make sure that we include lots of rich sources of unsaturated fatty acids. So that could be oils, avocado oils. There's that whole thing about like seed oils or fear around seed oils. I get that question a lot. There are tons of studies out there have shown that seed oils can actually be very protective, right? They're sources of unsaturated fat, but we also know there are ones with higher omega-3 fatty acid profiles like that olive and avocado oil. So if you're looking for that benefit, go towards those oils more often. But decreasing those saturated fats and replacing them with unsaturated can be very, very helpful for protecting our heart health and decreasing our risk. We've also got lower fat and fat-free dairy. I love dairy as a protein source, fantastic source of calcium to support blood vessel health. But we also know that higher fat dairy does contain some saturated fats. So we just want to be aware of our portion size and how often we are eating those saturated fats coming from dairy. Sometimes people are talking to me about their diet and they're going like, my cholesterol's high, like what can I do? And they're not eating like any meat products, but they're eating like pounds and pounds of cheese. So we work on, okay, if we're having cheese, let's look for a lower fat content cheese. Other dairy products, right? Pick and choose. If you're doing a lot of a source of dairy product like milk, we might not want to go for whole milk. We might want to go for a lower fat content milk, hopefully reducing the fat load and fat content of that specific thing. There are specific plant-based milks. If you're interested, they're not necessary, but if you prefer them, they are usually fortified with essential nutrients that are similar to milk. We just want to be aware that they're not like flavored. They usually carry extra sugars. So if we're monitoring our sugar, we might not necessarily want vanilla flavored milk because that might kind of cause a spike. Then we have some physical activity guidelines as well with this plan. Physical activity we recommend across the board. And I love what Dr. Hosmane said about walking. I get so many people who are like, well, I just like take some extra laps in the store or I park my car farther away. I'm like, that is amazing. Walking is going to give you lower intensity, but higher frequency of movement. So I think I hear all the time that sedentary is the new smoking is like what people say just because it's hard on the heart. So being sedentary for so long, not moving your body. So walking frequently, keeping an active lifestyle is fantastic. But we also love to encourage some muscle strengthening. So having that is fantastic in a regular routine to help improve our blood pressure. But also it makes your insulin more receptive to your glucose. We're building lean muscle mass, which not only in turn helps your metabolism and support that well, but it helps to manage those blood sugars, which in turn, helps our total heart health as well. So we aim for about 150 to 300 minutes a week. For example, 150 minutes is 20 to 30 minutes, 5 days a week, and you can split that up. We talk a lot about that in counseling on how to make a SMART goal with exercise, specific, measurable, attainable, time sensitive, to make it something that you stay consistent with. And the best exercise for you is one that you enjoy, one that feels good for you, and one that you can stay consistent with. As Dr. Hosmane said, limiting alcohol and age matters, right? It's different for every person. So like you said, 65 and older, the recommendations may change. It might be better to cut down alcohol in general. Standard guidelines is the 1 alcoholic beverage equivalent to 12-ounce beer, 5-ounce wine, 1.5 ounce of 80 proof liquor. Men and women with a differing recommendation, always individual risk factors, right? If your risk factor is high, we might want to change that recommendation. So it's always talking to your provider about what is best for your specific health needs. So just going into some daily recommended servings and food groups. So this is based off a 2,000 calorie diet. Basically, you can see here the different amounts of servings that we would recommend for grains, proteins, vegetables, fruits, sodium, nuts, seeds, lentils, all of those things. And what does a serving look like? So if I say 2 to 3 servings of vegetables, that can get a little confusing sometimes. So we like to break it down kind of with either visual reminders of like a serving of protein is the size of your palm, a serving of vegetables the size of your fist. But if you're looking for kind of specific cup measures, it could look like a half a cup of raw or cooked veggies, 1 medium fruit or half a cup of fresh or frozen, a tablespoon of fat. So if we're saying 2 to 3 servings of fruit per day, you might have half a cup of berries at lunch and maybe an apple, around midday snack. And that would, quote unquote, meet your needs for the day for fruit. There are some great Links I listed below just for some more information on what is a serving size, what are you looking for. So great education on the DASH eating plan specifically, but also, heart health and serving size linked together as well. So just a summary to wrap it all up. I really love to preach that all foods fit. There's a lot of misinformation out there on social media, on the internet, and it's causing a lot of stress for the most part. And stress isn't good for the heart, isn't good for the blood sugar in general. So we like to say that all foods fit because any food can fit into a healthy dietary pattern. But we need to focus on your specific needs, right? We want to make sure we choose more nutrient-dense foods, and then we work on how do we incorporate those other fun foods in a way that supports your health needs. So think of relativity, right? If you're looking at a higher sodium product and you're like, I really want this product, okay, think about the rest of your day. If you're having a canned soup because that's available to you right now and you need to eat, okay, it has 500 to 600 milligrams of sodium. How can we limit sodium in the rest of your day? How can we make sure you're well hydrated while you're having that soup to help kind of offset? And we also know if you have a higher sodium day, okay, the next day, let's try a little bit better. Let's make some adjustments to our next day and the next day after that to kind of get our pattern going to where we can maintain consistent dietary patterns, but also you can't 100% eat wrong. There's no 100% way to eat perfect. So we know that we need to make small adjustments, daily shifts in our daily patterns, and that helps to hopefully alleviate some stress too, and having to make these big, health changing goals that can get overwhelming. So starting with removing salt from your table, changing the cooking method. Maybe you're going to switch to whole grain bread. Maybe you're going to try a plant-based option like beans or lentils instead of your meat product once or twice a week. Each of these small little changes is going to support those overall lifestyle changes and really work on that preventative healthcare because it is never too early to start on that preventative healthcare. All of these disease processes tend to be linked, right? Our dietary recommendations are very similar for a lot of different disease processes. So diabetes, heart disease, we change a lot of the same similar things because it's going to reduce risk in all of those other areas too. So small shifts, taking it one step at a time, working with your healthcare professionals, because we'd love to work on prevention and treatment, but it's never too early to start. And that is it.
Thank you both very much. Are there any last comments, questions for today? No. All right. Well, thank you. We appreciate you joining us today, Dr. Hosmane. And thank you, as always, Caroline, for giving us our nutrition update. Have a great rest of your day.
Thank you.
Take care. See you guys later. Thank you.